I want to use this opportunity to welcome all of us to one of our series of webinars, and probably the last for the year 2024. And today we'll be talking about hysteroscopic myomectomy, tips and tricks. So our guest lecturer is seated already. So before I invite the moderator to take over the session, I would like to call on our acting presidents, Dr. Adewale Adebayo, who has been very active and has been able to allow us to have back-to-back 2 sessions of webinar within 1 month. So to give us the opening remarks. Mr. President, sir, Dr. Adewale, over to you.
Good evening, ladies and gentlemen, members of Aegis, all invited guests and participants present. Let me start by appreciating our guest speaker, that's Professor Norman Gomez, for making tonight possible. I know he's fully prepared to give us the best tonight. On behalf of Aegis Nigeria, we appreciate you, our moderator and our panelists, eminent and wonderful people. We appreciate you also. Thank you for coming around to lend your voice to the discussion that is about to begin. Lastly, I want to appreciate all our members within and outside the country for your regular support and attendance of our conferences and meetings. Going forward, we want to ensure that our webinars becomes more regular and stimulating. So please, let's sit back, relax, and enjoy tonight's package. Thank you very much.
Okay, thank you very much, Mr. President. At this point, I'm going to invite our moderator, who is no other person than Foundation Chairman, Dr. Onu Sunday Omali, a consultant obstetrician gynecologist and the medical director of Dida Hospital. Dr. Onu is a fellow of the West African College of Surgeons, fellow of the National Postgraduate Medical College of Obstetrics and Gynecology, fellow of International College of Surgeons. He is a faculty and resource person in many postgraduate training institutes. He has authored and co-authored several original and reviewed articles in both local and international peer-reviewed journals. Several chapters in reputable scientific textbooks in obstetrics and gynecology. He is also a reviewer to many scientific journals as well. He is a member of various professional bodies locally and internationally. Dr. Onu, like I mentioned earlier, is the chief consultant obstetrician and gynecologist, the former medical director at NISA Premier Hospital, Abuja, and the lead fertility specialist and endoscopic surgeon at the medical director of Dida Hospital, Abuja, Nigeria. A very good friend of the house and a reliable partner and boss, Dr. Onu. You are welcome. You can take over the mantle and introduce your the guest lecturer as well as the panelists, and then probably read the rules for the session to us. Dr. Onu.
Thank you very much, Dr. Akintobi, Director of Training, the President in the House. My special regards to you and the entire members of Aegis. It's a pleasure to be here today as a moderator of today's event. Very rich event with so many highly placed and talented panelists and guest speaker. Not to take our time, I'm going to introduce our panelists. I will want to implore that we should be straight to time, and so that we don't keep people unduly long in this session. Our guest speaker is no other person than Dr. Norman Gomez Diaz, who is a friend of the house, obtained his specialist qualification in obstetric and gynecology 2016 at the Hospital Clínico University in Valencia, Spain. And immediately he transited to be the head of the surgical department at the Equipo Médico Crespo Fertility Clinic, where he is master in surgical management of deep infiltrating endometriosis, is fellow in minimal invasive surgery for benign conditions, and he master in hysteroscopic surgery, which is one of our main target today, and had the training in ultrasound of pelvic pain. If you know, I mean, pelvic pain is one major thing that our women dread these days. And since 2019 to date, he has been a consultant pelvic surgeon at the Quiron Hospital in Valencia, Spain. He has 7 years experience in fertility enhancing surgery, for which the subject of today is a core center. And I mean, his current surgical activities will interest you to know that he performs about 80 hysteroscopic procedures per month, 120 laparoscopic surgeries per year, out of which we have 25 deep infiltrating endometriosis surgery per year. We are opportune to have a very, very wonderful speaker today that is going to throw more light on the topic, hysteroscopic myomectomy tips and tricks. We have 3 panelists. I'll quickly introduce them so that when we start, we won't be going back and forth. We start from our very, very own friend, Alexander Ogo, who is a consultant gynecologist and head of a gynecological service at Mid-Yorkshire Teaching NHS Trust in Wakefield, UK. And he has over 2 decades in minimal access surgery experience. He started his foundation in medicine from the University of Benin, where he obtained his MBBS and moved on to Obafemi Awolowo University in Nigeria for his residency training, where he obtained his fellowship and also had a fellowship in the Yorkshire Deanery in UK. It will interest us to know that he is the RCOG, regional preceptor for advanced training in hysteroscopy. So you can see why we say we are lucky today to have such an experience amongst us. The next is Dr. Ibrahim Rai, who is a consultant gynecologist at the National Hospital and very, very deep in infertility management and hysteroscopy, endoscopic surgical skills. And he's also a senior lecturer at the Bayes University here in Abuja. Dr. Rice has been a friend of the house and also an ESCO of this association. The last but not the least panelist is our own Dr. Moses Fache. Moses Fache is a consultant gynecologist whose major interest is in infertility and endoscopic surgery. He is the CEO and the MD of ProCare Hospital here in Abuja. I would like to summarize his introduction as this because I know him by heart. So we won't end if we continue this way. So now I'm going to give the floor to our speaker, to give us the meal for the day. And that meal is very sumptuous. And our appeal to us to listen very well. Put all your questions on the chat box. I'll be watching out for them. Put all the questions on the chat box so that at the end of the discussion, would have summarized the question and we'll have a smooth ride. Dr. Norman Gomez Diaz, the floor is yours. Thank you very much.
Thank you, Dr. Anu. Can you hear me well?
Yeah, we can hear you.
Okay, perfect. So, good evening, everyone. I want to say thanks, obviously, to Dr. Adewale for sure for inviting me to participate in this wonderful session, and also all the organizing committee, Dr. Onu also for these kind of words. So let me share my screen. Okay. Did you see the screen well? You see my slide?
Yes, we can see your slide.
Okay. So I'm here to talk about a few say about the hysteroscopic myomectomy, and I'm going to attempt to give you some practical tips to try to improve your daily clinical practice. So, Dr. Onu say, I work in a fertility center since 8 years ago, more or less. So we have a particular way to do this kind of procedure because normally we are more conservative with the endometrial cavity because we need to optimize the embryo transfer after the surgery. So we try to avoid the use of energy in some way inside the uterine cavity to preserve the endometrial cavity. I will share my vision about this kind of procedure and hope this help you in your daily practice. So there are the prevalence of the fibroids is very high, and there are many reasons why we need to remove the fibroids. Approximately between 20–50% of patients have symptoms related to the fibroids, and the main symptoms are, for one side, the bleeding, abnormal uterine bleeding, of course. It represents the five cause of hospitalizations in the US, and also it represents the first cause of hysterectomy in women with young age. And also, of course, the reproductive dysfunctions relate with the fibroids, mostly with the fibroids associated with the submucosal component have a low clinical pregnancy rate, low implantation, and ongoing pregnancy. And obviously, the surgery helped to solve this kind of problem. So the surgery relieved the symptom of the patient in 75% of the case. And in terms of pregnancy and miscarriage, increase the pregnancy rate and reduce the miscarriage possibilities. So the surgery is a good option in the fibroids and more with a submucosal component. So we need to have a clear points about the indication of the hysteroscopy in the approach of fibroids. So the figure established nomenclature about the disorders related with the uterine cavity as a submucosal fibroid. Specifically, this type of fibroid, the 1 and 2 type fibroids, are the most typical fibroids that we can approach by hysteroscopic procedures. But in 2018, even the type 3 fibroids, the figure sent a statement about talking about this kind of fibroid that share some common properties with the rest of submucosal fibroid because it's near to the mucosal of the endometrium, so can have a behavior similar to the classic submucosal fibroid. So we need to take this in account because in some occasions we need to, and we can also approach this kind of fibroids with the hysteroscopy. Also, the last mark group sent another classification and also establish a score that help us to make the decision to see the feasibility to approach a case of myoma by hysteroscopy. So the LAFMAR classification take in count the penetration, the extension of the base of the fibroid, also the topography of the lesion, and also the size. And with these parameters combined, we can have some score that we can correlate with the surgical time and also the difficulty to perform an hysteroscopy to do a myomectomy. So this, for people with not so much experience, this is a good guide to before start a procedure like this, because correlate well with the time of the surgery. A more score, we have more time to perform the surgery, and the time in hysteroscopy means liquid input, and this is a typical consideration that we need to know before approach these cases. There are other papers that try to correlate another variables with the necessity of a second procedure to complete the job. The main variables are the number of the fibroid, the size, and also the figure grade. It seems like 3 centimeters fibroid will be or predict a very difficult procedure by hysteroscopy. So this is like a starting point, our guide, before approach this kind of cases. So we need to start before approach myomectomy with the imaging technique. This is my personal opinion. We need to study very well the case, and to do that we need to use the ultrasound or the MRI. It doesn't matter whatever you use. For me, it's almost the same, but I can tell you that the MRI can add other advantage. For example, in polymyomatous uterus, is more precise to study the localizations of all the fibroids and the limits, and it's not operator dependent, the MRI. So it's a good tool, but whatever you use will be the same. Today, with the new imaging techniques, is comparable both techniques. So we need to take in account a lot of things, because the imaging technique will be our GPS inside the uterine cavity to solve the problem of the patient. So we need to know how high is the myoma, which wall is located. It's not the same a myoma in the funded area than in the lateral wall of the uterus or the inferior part of the uterus. This is another aspect important, the free margins of the up to the serosa from the myoma onto the serosa of the uterus, because knowing that we can go with confidence during the surgery to approach the cage without the fear to perforate the uterus or complicate the case. And also we can evaluate here the laterality of the lesion. So I'm going to share with you, this is some simple ultrasound images, and this is some aspect that I normally take in account when I going to approach an hysteroscopic myomectomy. So we need the longitudinal section of the uterus and also a transverse section. Here we have 3D. Is not necessary always the 3D ultrasound, but with the image in 2D planes, we can study very well the situation. So here, for example, I normally take in count the height of the lesion. I normally divide more or less the uterus about in 3 parts. For example, in this particular case, have the myoma in the superior third of the uterus. Also, we need to measure the diameters of the fibroid, of course. This is another aspect to take in count. And also, we need to measure the distance of the fibroid up to the serosa. This is another important point because during the surgery, we need to approach in this line because we need to attack the pseudocaxual plane to detach the myoma from inside. So this is important taking count because we can go with confidence during the surgery. And also in the other plane of the image, we can divide the uterus in 2 parts. This is the right side, for example, this is the left side. So the myoma is located in the right side in this particular situation. We have in the cornwall area. So this is important to know. So the conclusion evaluating this image is the side of the fibroid, also the distance from the myoma up to the serosa, the diameter is another important, and the localization in the superior third, because this will be our GPS inside the operating room. So I think this is my opinion, the distance, the optimal distance between fibroid and the serosa, safety distance, I can say will be 5 millimeters, more or less. 5 millimeters, I think is enough to go with confidence to approach a case like this, for example. Okay. So the planification of the surgery is another important aspect. If you, for example, going to perform a deep endo surgery and you plan to do a bowel resection, for example, you need to prepare the bowel before the surgery. In the endometrial cavity, we need to prepare for the surgery, and the thin endometrium is a good aspect to take in account to localize with precision all the fibroids and to have a good vision inside the uterine cavity to approach the case and to do more easy our life during this kind of surgery. On the contrary, we have here, for example, we have a thick endometrium. So a thick endometrium is a problem. This is the ultrasound. In the same case, you can see here the endometrium is very thick. So we have the myomas located in this particular, the anterior wall, and also in the posterior wall, we have another fibroids. But inside the uterine cavity, we can miss the lesion. We can miss the fibroid, and we can think that the uterine cavity is totally normal. And if the patient has a problem of bleeding or infertility, we cannot approach this particular case. Here you can see, for example, this is the surgery of the thick endometrium. You need to fight with the endometrium to expose the fibroid before do the surgery. And if you don't have too much experience, you can miss the fibroids, you can do an incomplete job, and you can have complications. As you can see here, we know that we need to go directly to this wall because we have the information of the ultrasound, of the imaging techniques, and doing like this, we cannot miss. We know the exactly localization of the fibroids, and now we go for the posterior wall because we see in the ultrasound that we have another fibroid here. We eliminate the superficial endometrial line, and we expose the fibroid, as you can see here. And as you can see, if you go for a surgery without a good endometrial preparation, this is time. This is time that you use to try to reduce the endometrial line, to approach the case and to try to visualize the lesions inside the uterine cavity. So it's important to take in account this. So combine contraceptives, and also even the same day of the surgery, you can still aspirate the endometrial cavity before the surgery. As you can see here, we have a thick endometrium, is premenstrual endometrium, is difficult to orientate inside this cavity. So in this particular case, I normally use a Karman cannula or aspiration cannula of 4 millimeters to aspirate the endometrium, and now it's better the vision. You can see the walls and you can work without problem like this. So the endometrial preparation, it seems in studies that can improve the operating time for sure. The distension media absorption is reduced a lot. The possibility of second procedure because you do an incomplete job, and also can reduce the complications. So there is an important aspect to consider during the approach of this surgery. Is interesting is the concept of the pseudocapsula. Pseudocapsula is myometrial zone adjacent to the myoma, to the fibroid, that is clearly identified both from the imaging techniques like MRI, as you can see this white halo surrounding the fibroids, and also with the ultrasound, as you can see in this area. And from the histological point of view. So the pseudocapsula contains a lot of neurovascular network in reproductive field. Mostly is important for the healing process if you preserve this capsula. So this is the vision of the one of our case. This is a pseudocapsula. After the enucleation of the fibroid, you can see the vascular network there. And you can use the bipolar tick to selectively coagulate the bleeding vessels and preserving all this vascular network. For the healing process, it seems in studies that can improve the healing process. You can see very well all the vascular structures and you can preserve it. Like all in the endoscopic surgery, this kind of surgery is instrument dependent. So normally I usually use this instrument for approach this case. In simple case, and in my opinion, simple case means less than 1.5 centimeters myoma, or less than 1 centimeters myoma. So we can approach with the simple Betocchi hysteroscope system, and we can use the sharp scissors, the positive forceps, and also the bipolar tick, as you can see in the previous video. And also I suggest to use this Randall forceps. This is a forceps that is useful to extract the myoma after the surgery. But we need to dilate the cervix to do that. And on the other hand, we have instruments for complex cases. This is that I mostly use. This is a tissue removal system device. This is from Medtronic, for example, but you can use whatever you want. all these devices have a big operating channel, so we have a strong material to do the surgery inside the uterine cavity, a strong scissors, a strong graspers, and also we have the bipolar tip also. This is the blade to extract the tissue by mouth selection, and we have this kind of myoma screw. It's a small myoma screw. It's a good help to pull the myoma from the pseudocapsula and to detach in complicated cases. So you must know that the Betocchi hysteroscope is the instrument that I mostly use, and this is a fragile instrument. We use very tiny instrument. Normally we use the sharp scissor because we need to dive into the pseudocapsular plane and to detach all the myoma fibers. This is an incorrect way to use the scissors. You cannot work like this because it's fragile instrument, so you can break very easily. So I recommend to align the axis of the scissors, as you can see here, and also in this superior part of the slide. And you can align with the working channel, and doing in this way we can protect the scissors from the breakage. This is our experience seeing cases that consult us for fertility problems. So this is the reason why we don't try to use the energy inside the uterine cavity. This is the first case. This is a patient. You can see the ostium, the right tubal ostium. You cannot see the left one. This patient have an adhesion, an Asherman in the left hemicavity of the uterus. So the patient consult for fertility problems. All these cases consult for fertility problems. So we do the job with the scissors, as you can see here an endometrial cavity, a trap in the myometrial line is because have adhesions there, and you can see right now this is an endometrial patch. These are sequelas of the resectoscope. I'm going to accelerate. You can see this is typical aspect. This dark area represents born tissue with the energy. So this create more adhesions inside the cavity. There are papers that tell us that this is the typical aspect of this kind. You can see these blood areas. This is another case that we have. This is an incomplete myomectomy. This surgery was performed with a resectoscope. Again, you can see the blood areas surrounding the pseudocapsular plane. As you can see in this area, for example. And the last case is almost the same. We can see here, after free the adhesions inside the uterine cavity, we can see in the superior part, we have the typical black areas. That's the reason why normally we don't use the resectoscope to perform this kind of surgery. I'm not saying that you cannot use this kind of dispositive, but you need to be conservative if you are thinking in reproductive outcomes. Okay, you can use the energy, but with precaution inside the uterine cavity, because you are more risky to cause these kind of problems. So let's start with some procedures to see the technique itself. So here we have the information again of the ultrasound and also the imaging technique, and so that's the reason why we know where to find the fibroid. is in the anterior path. You can see here one of the limit of the pseudocapsule. So we need to go for the superior limit. You can see, you can approach, and with the scissors, you open the jaw in the correct plane, and the liquid do his job, entering inside the pseudocapsular plane and dissect some part of the pseudocapsula. So that's how you can visualize very well the planes. So now we move to the surrounding area of the myoma, and we do the same and repeat all the same to know all the limits of the fibroid. So we open the jaw. This is the methodology, I think. You open the jaw inside the pseudocapsular plane, and doing like this, you visualize the transverse fibers. And when you visualize the fibers, you change the direction of the scissors and cut it, and repeat this operation several times. To repeat the same operation in the other side. So this is a very dynamic surgery because you need to rotate the hysteroscope at some points during the surgery, rotate the scissors. In some ways, it's complicated to do that, but with experience, you gain a lot of training with this, with the movement of the hysteroscope, and you can perform this kind of surgery. When you detach all the surrounding tissue of the fibroid, you can use the tip of the scissor to pull the myoma inside of the uterine cavity, as you can see here. Doing like this, you can break a lot of attaching fibers of the myoma from the pseudocapsule, and you rotate the hysteroscope and try to cut the rest of the transverse fibers. You can see here it's almost done the surgery. The final fibers we are cutting there. And that's it. And we preserve all the pseudocapsular plane. This is another case. This can help you. You can see how you can reduce the pressure inside the uterine cavity and put in evidence the fibroid. But also, it's important to have the imaging techniques to complement the orientation inside the uterine cavity and to know where to find the fibroid. So we reduce the pressure, the myoma bulk inside the uterine cavity, and we know more or less the localization, and as in the previous case, we localize the limit of the pseudocapsule. Is the same operation every time that you do this kind of work. You can go inside the pseudocapsular plane with the help of the scissor, and rotating the scissors, you can cut and separate very well the pseudocapsular plane and detach the fibroid from all the surrounding attachments. And you can see very well here how you preserve the endometrial layer. So we are working always in the pseudocapsular plane. Another aspect important is to visualize the movement of the tissue, also the color of the tissue, because these are some clues to help you to identify the limits of the fibroids, and also the pseudocapsule fibers. Finally, when we detach almost all the fibers, we can use the grasper, as you can see, and we can pull inside the uterine cavity and detach the fiber from the final attachments. But to do that, you need to cut a lot of fiber, because if you only expose the fiber and pull inside, you can break the grasper very, very easily. This is one aspect in this particular case. You can see, as you can see, this more white area and almost round area here. This is another fibroid behind the first one. So you can identify with the colors of the tissue, because you can see this uniform white structure there. And also you can compare with the subendometrial line, all the trabecular tissue surrounding the fibroid. So you can look in this, the aspect of this tissue, we can see very well all the fibroids. Now I'm cutting, you can see the difference of colors. The myoma have this shining white aspect than the rest of the tissue. You can see it's more pink tissue surrounding. And at the end, I use also the grasper to complete the extraction of the fibroid. So we have two fibroids here. You can see the pseudocapsular plane. This patient have another problem, have a thick lateral wall. So I normally, to accelerate the process, I reintroduce the fibroid inside the pseudocapsula to gain space inside the uterine cavity to continue working inside the uterine cavity. And in this particular case, I cut the laterals and also the fundus. Okay, this is another case. We have a single fibroid surgery with the tissue removal system device. Again, we reduce the pressure inside the uterine cavity. The endometrial preparation is very well. It's a thin endometrium, but we can use here a very strong scissor. This scissor is better and faster to enucleate the fibroid, because if you open the jaw of the scissors in the correct plane, not also separate the fibroid, but also at the same time break the attachments of the fibroid at the same time. So you can save time doing like this. And finally, we pull inside of the fibroid and use the blade to extract the tissue from inside the uterine cavity. So this tissue removal system device don't make the work for you. You need to expose very well the fibroid to the blade to complete the job. This is the aspect after the surgery. This is the pseudocapsular plane, the fovea of the myomectomy. And this is some picture of the long-term result after 2 months of the surgery. You can see the healing process is very nice. This is another complex case. This is a multiple fibroid surgery. Again, with the tissue removal system, we can approach this case. You can only see inside the uterine cavity 2 fibroids, but again, with the ultrasound and the imaging technique, we know that there are more fibroids inside the uterine cavity. So we need to go. I personally go for the difficult fibroid first. It's always the same process. You expose some part of the fibroid, then you introduce or try to localize the one of the limit of the pseudocapsule, and this will be the starting point to detach all the fibroids from the surrounding area. We have another fibroid here in the cornual area. We expose the fibroid, we follow the pseudocapsular plane, or we try to expose, as you can see. Just a simple type 0 fibroid. It's easy to extract. Also, the patient have another in the posterior wall of the uterus. Again, you expose the fibroid. You go under the fibroid, between the fibroid and the pseudocapsular plane, and you try to pull from behind to elevate inside the uterine cavity, as you can see here. And now we use the blade to extract all the fibroids that are inside the uterine cavity. This is the final result of the surgery. You have a lot of phobias from the myomectomy. And this is the aspect after 2 months of this kind of surgery. You see all the phobias are very well healed. So in short term, we can proceed with the embryo transfer in this particular case. This is a good example of how to combine instruments Sometimes, if you have a lateral fibroid, you need to open the lateral wall of the uterus to approach this particular case, because you must know that the instruments are straight. So sometimes you cannot gain access to the fibroid if the fibroid is too lateral. So we need to sometimes open a lateral wall to get exposure of the side of the fibroid, as you can see here. And we follow the pseudocapsular plane. I'm doing this case with a Betoki system. This small scissor is very fragile for this kind of fibroid because it's too big, this fibroid. You can see here we are totally inside the pseudocapsular plane. This is the fibroid in the upper side. The inferior part is the pseudocapsular plane, and we can dive inside the pseudocapsular plane. Here I changed the instrument for the tissue removal system device to have more strength, and I use the myoma screw in this particular case because I see that it's a big fibroid during the surgery. So you have a good traction with this kind of myoma screw, and we leave the fibroid there. And at the end, we obviously use the morcellation system. This is the bipolar tip. It's a good complement during the surgery. And now we extract the fibroid with the blade. The rest is history here. This is another example of a combination of instruments. This patient have 3 fibroids in both laterals. We reduce the pressure. We can see and put in evidence all the fibroids here in this area. There are 2 fibroids here, lateral left, and also in the posterior wall of the uterus. We use the scissors, expose the fibroid, and always respect the endometrial tissue. We open the jaws of the scissors in the correct plane, and we can dive inside the pseudocapsular plane. When we cut a lot of surrounding tissue of the fibroid, the attachment is almost free. We can put the scissors behind and pull inside the free part of the uterine cavity. Again, we need a space here to do the other myomectomy. So we reintroduce the fibroid in the pseudocapsula, don't waste time, and approach the other fibroid. Now we use the morcellation device, the blade. And at the end, we have another small fibroid here. We expose the fibroid, and with the use of a grasper, you can see this grasper is a very, very strong grasper. You can finally enucleate completely the fibroid from his myomatous bed. And we extract with the blade. Again, you can see here the phobia of the myomectomies. Now, imagine that you use the resectoscope here. You will burn the lateral and also the posterior wall and the other wall of the uterus. So think about that if you are looking for reproductive results. So once you remove the myoma or the fibroid, what can we do? So normally when I use the Betoki hysteroscope, I use the Randall forceps guide with the ultrasound, and after the dilatation, we extract very easily the fiber. But normally I do this with less than 1.5 centimeter fibroid, no more. At least in my experience, because you can have problems with the cervix, with the dilatation process, and all these aspects. If we have a lot of fibroids or big ones, we can use the morcellation system, but it's an expensive device. But it's a good option if you have available this instrument. You can perfectly use. It's a very, very, very strong device. And at the end, there's a paper, a publication, a multicentric study that tell us that you can leave the fiber inside the uterine cavity in these multi-center studies with this size of the fibroid and the grade of the fibroid. We have, after the myomectomy, leaving the fibroid inside the uterine cavity. In 40% of patients nulliparous, we check the uterine cavity again 3 months after the surgery, and they have this result of 94% of expulsion rate after the surgery. So I personally doesn't let the myomas inside the uterine cavity. I try to remove all the tissue because I have the experience, like you can see. I don't know if we have time, but I can share with you. This is one case that I made. This is the MRI. You can see in the left lateral side we had a fibroid, and also in the anterior part of the uterus we have another one. We expose first fibroid, we go for the second one. I'm using the tissue removal system device, complement the surgery with the myoma screw to pull the myomas inside and to detach all the fibroids, as you can see here. And after this surgery, I leave the myoma there because I read this paper, and I leave the myoma there, and 3 months later, this is the result. In my experience, so you can see the fibroid again is inside the uterine cavity, but now the fibroids are attached in the uterine wall. I have 3 cases like this, sorry, 2 cases, and the other one, the other case, the fibroid was impacted in the cervical canal. The patient experienced pains and bleeding. So I personally doesn't let inside the uterine cavity the fibroid because this reason, because this, I don't know, small experience, but it's very difficult to redo the surgery after this kind of complication because the natural planes of the myoma are totally lost. So it's very difficult to detach again the fibroid from the uterine wall. You see all the attachments of the fibroid. It's a fibroid tissue. It's not easy to redo the surgery in this circumstance. Okay, at the end, I use the morcellation system, the device, and extract the residual tissue. So this is the scars after the surgery, and this is the final view of the uterine cavity. So I can share some points and difference with the 2 main instruments I normally use. This the Betoki system. This is the operating channel. It's more thin operating channel. So in general, it's more fragile, this instrument, but it's more easy to move inside the uterine cavity with this kind of instruments. It's very easy to move. The ergonomics is better for sure, and the rotation of the hysteroscope and all and the vision, I think is better. The weak point is that it's fragile, and the trochlear system or tissue removal system device, whatever you use, all are very strong instruments with a big diameter of the operating channel, so we can use even a mini laparoscope instrument to complement the surgery. But these instruments require, in my opinion, more experience because you add another I don't know problems during the surgery. That is, when you activate the blade, the uterine cavity collapse suddenly because the suction created by the blade. But with experience, you can approach this without problem. And normally, we perform this number of cases per year, the hysteroscopic cases. And for myomectomies, we perform nowadays at least two surgeries of two of these kind of surgeries per week, more or less, myomectomy. The volume is not so high for myomectomies at least, but the main message for you is that if you create the habit to work with the scissors, you need to start with simple cases like diagnosis, like polyps or small myomas, retaining product of conception with small residual tissue. This is your training camp to jump to do the complex case of myomectomy. But doing like this and training a lot with the scissors, you can gain more precision, of course, with the scissors, and also I think better results in the reproductive outcomes. And in long term, after doing surgeries with the Betoki system, with the small scissors, and you approach lot of cases, you can approach more complex case with the tissue removal system device if you have available. But I must tell you that you can approach at least, in my opinion, 80% or 85% of your cases with this Betoki instrument, with the simple Betoki instrument. So to conclude, there are many ways to do an hysteroscopic myomectomy. It doesn't mean that one kind of way is better than the other one, but the one you develop, you need to master and you need to train very well to have a good results. It seems like the cold techniques respect better the endometrium. There are no papers or publications that saying that the cold techniques have better reproductive outcomes today. We don't have papers or evidence about that, but there is evidence that the use of energy inside the uterine cavity create more adhesions inside the uterine cavity. This is one fact. So we need to take in count this. The most important for sure, beside the technique that you use, is the correct preoperative workup. And this means the good imaging technique access before the surgery with the MRI or the ultrasound scan, and also the good preparation of the endometrial line before the surgery to avoid complications. And remember, this is the pseudocapsular concept because it's a key concept in this kind of surgery, because the pseudocapsule is a plane that we can use for detach very well the fibroid, and we can reduce the complication during the healing process of these kind of patients. Thank you so much.
Wow. It's a wow. Dr. Gomez, thank you very much for this exposition. I will say that it's very lucid, very simple, very direct, and very plain, for our understanding. And I can see that you are so avidly, passionate about the code system compared to the energy system, and I've seen the dexterity, how you simply just maneuver the code instruments, to remove various sizes of fibroid. It's a very wonderful talk there. I want to give just little minutes to our panelists to just make some input before I go into the general question and answer. So, Dr. Gomez, just there's a lot of questions for you, that we'll learn from. Let me start from Mr. Alexander Obo. What do you have to briefly just tell us about today?
Dr. Onu, is it Professor Onu now? I'd like to say thank you. Thank you very much to Aegis for the opportunity. Dr. Gomez, your presentation has been amazing. Okay, I think you're pushing me to the point of understanding a solution to a problem I've been having debates with Professor Okohue about at the last AAGL meeting in New Orleans.
Yeah.
I think my summary of tips and tricks of hysteroscopic myomectomy is simple. I use the word SAPP. You got to look at the surgeon's skills, which was what I think your last but one slide talked about. where you put the curve. It's how skillful are you doing the hysteroscopic work? Have you got the skill and the training? That's important. And what's the availability of your equipment you need? You have the beauty of having the Betoki, and you also have your TrueColor system. You've got your myomectomy screws, you've got your fine scissors, you've got your rigid scissors, and also you've got your musculator. Those are the things you got to think as a surgeon, especially in Nigeria, which is our main audience here. If you're going to be doing this, have I got the equipment to deal with it? Then you're going to look about the patient's limitation. That's the first P. Are you doing this under general anesthesia? Or are you under local anesthesia? Because what you do and what you can do is different in the setting in which you're doing it. In the UK, we have outpatient clinics. So the small polyps, the small fibroids, type 0 fibroids, type 1 fibroids, we can enucleate them using the InMyoSure device, which is like the TrueClear in a clinic setting. And with patients awake, no local anesthesia, sometimes paracervical block, you can get away with that. Where we use Entonox. And then the pathology limitation, I think that's the key thing. Where you talk here about what's the size of the fibroid and what's the type of the fibroid. Is it a figure type 2 to 5, which like your slide talked about, the distance from the capsule to the serosa is important. So type 2 to 5 pretty much goes across. But a type 3, you may have a margin. And so, yes, you would show some type 3s, but you had done your pre-assessment scan to confirm there's a safe margin to work. But those are the things that are very, very important. And if you can get that right, then you should be able to manage things pretty much safely. But what a lot of people don't do is to get that bit absolutely right. So I'm really, really impressed that you got that right. And I think it's important that people understand that. So thank you very much. The other thing, which is the final bit, is the debate about do you resect with a bipolar system or do you use the cold scissors, especially for fibroids. Most women in Nigeria will do the fibroid surgery because of fertility issues. And if you resect a de novo cavity and you create adhesions, you're pretty much confining that woman to repeated IVF failures or repeated resection of those adhesions. It's important that people learn the technique you're pushing today. If you can do things with cold scissors, the evidence emerging that there are fewer risks of developing adhesions. Because with the resections and having adhesions, we don't have a good quality adhesion prevention methods. We've had this debate about using the balloon, is it silicone balloon, is it rubber balloon? We've talked about IUCD, highly barrier adhesion prevention gel. It's no quality evidence. There was something somebody brought the AGL in New Orleans this year. No quality evidence to suggest what is the safest and best thing to do. So I think if we can get away using cold technique, we may be helping our women in Nigeria reduce that risk. But it's a steep learning curve. But it's learnable, and we can do it. Thank you.
Oh, thank you very much, Mr. Obo there. Very lucid one too. We are gaining quite a lot. I particularly am getting more and more interested in this. So I move to the next panelist, Dr. Ibrahim Rais. Give us a brief.
Thank you, Dr. Gomez. The presentation is very lucid and splendid. What take-home message our audiences and myself to ponder upon is that before you embark on your surgery, define the extent of the problem. If you don't define the extent of the problem, you run into issues midway. The second thing is, with the use of the cold scissors in our environment where power management, cost of equipment is higher, it's easier for me to lose a scissors and replace it than to buy a resectoscope and the elements. It's easier. But the learning curve is what is key. And the other aspect is use of MRI. It has been shown to be superior in defining the extent of the pathology. but how many centers have MRI readily available in our environment? So a good hands-on training in ultrasound will help the hysteroscopic surgeon define the extent of the pathology. Apart from that, I think you have said most of what has to be said in this aspect. Thank you very much.
Thank you so much.
Thank you very much, Dr. Rice. Very key, I mean, hitting on MRI, even with very few availability of MRI in our setting, there's also a problem of interpretation. It's not just even for those where it's even available. I mean, interpretation is a problem because uh, the learning curve in terms of radiologists interpreting and even us interpreting is also one of the things we have to look into. So hitting on the scan, I was so amazed when I saw Gomez scan. He's using a Voluson P8. You know, am I right? Gomez, Voluson P8 GE scanner, right?
Yes, that's it.
All right. I mean, and I'll tell you that we have a lot of them in Nigeria. So it's just to improve personal skill in the use of ultrasound scan. I know resolution is high. Some other Philips scan and Mindray have good resolution that will actually help us. So I moved to, he said, Dr. Fache there. I can't see him online.
Yes,
Dr.
I
Fache?
am.
All right. Okay. Yeah, please
Yes.
give us your brief.
All right. Thank you, Professor Gomez. I think one of the challenges with doing hysteroscopic myomectomy, apart from trying to do fibroid mapping, is determining the size of this fibroid. So one of the mistakes is for someone to think that if you have a 4-centimeter fibroid, for instance, it's just double the size of a 2-centimeter fibroid. Because when you're using a resectoscope, for instance, where you're going to be slicing gradually, you would soon realize that the volume of a 2-centimeter fibroid is about 4-centimeter cube, whereas that of a 4-centimeter fibroid is about 33 centimeter cube. So there's a difference of about 29 centimeters. And so when you set out to resect this fibroid, then of course, if you have that erroneous impression, you're going to run into trouble. And so again, looking at the figure classification, if you have type 2 fibroid, mostly there's going to be a challenge because most of it is within the intramural portion. And so in 2009, Betoki pioneered a method, that's the opium technique, where they actually slice the pseudocapsule, allow the forces of the myometrium to push in. So it's more like downgrading submucous fibroid, especially for type 1 and type 2. And it has helped people who have less skill to be able to downgrade a type 2 the submucous fibroid to type 1, for instance, sometimes type 0. So they do not remove the pseudocapsule, come back in 2 months' time, and then try to resect it. And so that has been what is, I mean, some of us who want to dive deeper into doing difficult myomectomies do. However, the type 3, figure type 3 has been a challenge. And there have been a lot of debate, okay, maybe you just leave it. So what I can summarize Professor Gomez's technique is like doing laparoscopy hysteroscopically. That's what he has demonstrated today, where you can actually, via the hysteroscope, dig into, into this myometrium by removing just the endometrium, and then you're able to either extract the fibroid from its cavity and bulk and then musculate it. This is just similar to what we do in laparoscopy. And so I think it's a step further. Where you can probably do like some of those fibroids that were removed were like figure type 3, because with the aid of MRI, you're able to locate the actual positioning. So when it comes to tips and tricks, I think this is actually a step forward. I must comment that the instruments are expensive. I have a TrueClear Elite, and the disposable seal is 250,000 naira. It's disposable, single-use seal of that TrueClear Plus that he uses. So if you're going to do this kind of procedure, then you should also be ready to invest a lot in good equipment, because those 3mm tools would not go in through the regular hysteroscope that we are used to. So I think that's just my comment. I want once again to thank Professor Gomez for presenting a lucid talk. Thank you.
Thank you very much, Moses Fache. It's a wonderful one there to all of us. So, Mr. Gomez, there are some questions from the audience. I will take them two at once so that we'll save some time. There's a question that, what intrauterine pressure or fluid pressure do you work with? Then, is there any restriction to the number of fibroids you remove per procedure? Intrauterine fluid pressure that you work with in your experience. That's one question. Another question is there a limit to the number of fibroids that you remove per time?
Okay. So normally the setup, I use the Hamu and the Mac Select machine. So normally the setup that I use is the pressure in 200 millimeters of mercury, and also the flow rate at 400 millimeters per hour. So we do all this kind of surgery. All the surgeries that you see in the slides are in the operating room. I do not perform surgery in office or surgeries like this in office. And this is the pressure that I normally use inside the operating room. But the pressure is just a number, because sometimes you cannot know exactly the correct or the exact pressure inside the uterine cavity, but this is the way that I find to see better inside the uterine cavity, okay, with this high pressure in the setup. And the second question was, sorry.
What's the maximum number? Is there a
Maximum number?
limit
Yes,
to
yes,
the
sorry,
number?
the maximum number. Okay, so normally when you have a lot of fibroid, you know that is a lot of time-consuming surgery. But I try to resect as much as I can. I don't have a number to decline for the surgery, so I go for the surgery. But I only there is one thing that I do if I have a lot of fibroid. If I have a lot of fibroid, I mean, I don't know, maybe 5 fibroids, and I start to detach fibroids, and during the surgery I decide to continue or not, and the decision is with the liquid input. So I have a nurse inside the operating room with me all time, doing the checking the liquid input for me, and this nurse tells me every 5 minutes about the input of liquid. If we are okay with the liquid, we continue with the surgery. But if we reach some limit of liquid, I try to stop the procedure and do not perform more the surgery. So there is not a limit. It's the behavior of the patient during the operating room.
Okay, that's fine. Another question is, do you use the Covident Elite TrueClear for your 3mm instruments or the Bugatti shaver?
No, we use the Covidien, the Medtronic TrueClear system device, is the bigger one. It's 4 millimeters the operating channel and 7.2 millimeters of the external sheath.
Okay, good. There's a question to, apart from the trochlear, are there regular hysteroscopes that can accommodate the 3 millimeter instruments?
You asked me if we have a regular hysteroscope with this kind of, besides the Toki, the Toki is
trochlear.
the trochlear. Yes, we have another small one. I think is 3 millimeters, but I think the scissors doesn't work in this kind of small device. Also, the Ologit have almost the same instruments. They have a mid size instrument, a large size instrument. In the large size, you can use the same scissors that I show you here, but in the mid size, you cannot use it.
Okay. See, this question says, do you vary the fluid pressure during surgery? That's one. Another one is, what barrier do you use to prevent adhesion post myomectomy?
That's it. Perfect. So normally, if I use a barrier, it depends the situation. But I can tell you, if I resect only one fibroid in the other uterine wall, you will have normal endometrium. So the endometrium itself is an anti-adhesion barrier. So in this situation with only one fibroid, I do not use normally adhesion prevention. But if we approach a mirror myoma, for example, that you can have the basal layer of the pseudoendometrial exposed in both sides. So in that situation, I normally use mechanical barriers. I prefer the mechanical barrier, like a Foley catheter, for example, I can use for at least 2 or 3 weeks, depending on the size of the fiber, but more or less like this, 2 weeks, and after that we remove it. But I prefer most of the time mechanical barriers.
Okay. There's this question too, is what anesthesia do you prefer during your surgeries? General anesthesia or regional?
Yes, I do not decide this when I start to do the surgery. And all the anesthesiologists always work with general anesthesia. And I think it's a best way to do the surgery, because if you have the patient awake, because a Raki anesthesia, for example, if the surgery takes a lot of time and the liquid input is too high, it's better to secure the airway of the patient at the beginning of the surgery to avoid problems with the liquid and to manage the liquid during the surgery. I think general anesthesia, in my opinion, is better for the surgery.
There are 2 more questions, and we'll wrap it up. You see, with free floating myomas, because I mean, from your when you did the multiple myoma, a lot of them were freely floating. You know, does not that not pose a challenge for you to resect? I mean, using the tissue retriever. Why didn't you leave the stock or so on the base, before introducing the tissue retriever rather than removing all the fibroid?
Yes, it's a good question. You mean that I only expose the fibroid and leave it there without detaching at all for inside the uterine cavity? Okay.
Yeah.
I think you need to expose very well the fibroid from the window of the blade. You need to expose very well too, because the blade sometimes do not have too much suction force to detach the fibroid from the uterine wall. So that's the reason why I detach completely to expose and put in contact better the fibroid with the window blade of the blade to do better the job. I try to sometimes in very, very big myomas because we don't have a space inside the uterine cavity. It's so big that you cannot pull inside the uterine cavity. So in that situation, sometimes I use the blade and put in the inferior part of the fibroid, looking to the superior part of the uterine cavity. That's it. And start to reduce the volume of the fibroid to complete the job. This is an option, but normally I detach at all, and after that, extract.
Okay. Then what is the safest myoma serosa distance to avoid perforation?
Yes, I must tell you that this is a matter of experience. This is the simple answer. So there's a safety margin. I think is 5 millimeters. 5 millimeters, but it's like when you approach this mosel. If you have more than 5 millimeters, other authors prefer more than 3 millimeters is safe. It's a matter of experience. I think for beginning, 5 millimeters is not do not do a perforation. But sometimes I approach cases because you are always in contact with the fiber. When you localize very well the pseudocapsule, you maintain always in the pseudocapsule and no. I also in some occasions in one part of the fiber I have 3 millimeters, but this is a matter of experience.
All right. Final question here before Rice will talk. Do you usually do second look hysteroscopy after your myomectomy? And if you do, how long after the myomectomy do you go in for a second look?
Perfect. So yes, if we perform very aggressive surgery, aggressive means a lot of fibers, more than 2 fibers. I suggest to do a second look. Normally, the way we do this is because in the first instance, the patient normally in fertility process treatment have an embryo before the surgery. Okay, so we freeze embryos, and after the surgery, we wait at least 1.5, 2 months. And after this period of time, we prepare the uterus for the embryo transfer, and we check the uterus with an ultrasound. And before put an embryo, 1.5, 2 months later, we perform in office a second look. That is the procedure that I use for office, second looks. But yes, 1.5, 2 months is more than enough. There are
All right.
papers. There are papers that tell us that it seems like the reproductive results doesn't matter if you wait 1, 2, or 3 or more months for the embryo transfer. It seems like at least 1 month is enough, but I think is the pathology is very complex. I think more than 2 fibers. I prefer at least 2 months.
Good. Dr. Rice?
Yes,
You have
sir.
your hand.
Professor Gomez, just like during laparoscopy, there are situations that make us abandon and convert into open. Have you ever had reason to use resectoscope in any of your series you have done? If yes, when?
Okay, perfect. So, okay, the question is if I use the resectoscope in any kind of surgery. This is the question.
Yes.
Okay, yes. There are some situations that we cannot solve with a scissor. And this is a very good question. Thank you so much. I must tell you that the cervical problems for me is a must to use a resectoscope because the cervical tissue is more is more hard tissue, so you can break very easily the scissors if you resect pathology in the cervix. And in the cervix, you don't have too much problem for the healing inside the uterine cavity. For example, the typical pathology is an isthmus cell. Isthmus cell, you cannot solve with a scissor. At least I don't know the way to do that. Isthmus cell is the typical, and also we have in some occasions in our daily practice very difficult embryo transfer because retroflex uterus or previous cervical surgeries like previous conization of the cervix, that a lot of fibrosis in the cervix. So to facilitate the embryo transfer process after the surgery, I use the resectoscope in the cervix. So all the problems relate with the cervix, I use the resectoscope.
All right. So I will say a very big thank you to Gomez. You've made our day today, and a very big thank you to the panelists for adding glamour to this interesting talk. And I will say very warm big thank you to all our members, all the participants that have focused their eyes and their ears to this team to the very last end. It will interest you to know that I've been checking on the number of attenders and nobody have dropped, meaning that, I mean, it's a good talk and we enjoyed it. Thank you very much, Abdulhakim. Over to you, sir.
Yeah, it's been a wonderful day. I've been glued to the screen right from the beginning, and it's a great job delivered by Professor Gomez there. The vote of thanks has already been given by our moderator, but it's not, we can't thank you enough for honoring our invitation without any hesitation. And as a director of training, I'm going to also act like an Oliver Twist. As an association, we do organize a periodic training for our members. This technique that you have introduced to us, we would like to have you as a facilitator in our next training program. So that, because training is important, we do know that following talks like this, people go to conferences, there's always that urge to start doing things without mastering what you want to do, and then complication becomes a problem. So for us to get our members well grounded, we will need to actually have to do some kind of tutoring, and cold scissors hysteroscopy will surely be part of what will introduce our next training program. And I know that if we call on you to join us for that program, you will not hesitate as usual.
For sure, taking come with me. I appreciate that. For sure, come with me.
Thank you very much. Thank you very much. You know, on behalf of our president, want to say a very big thank you to all the panelists, our wonderful moderator. You've been able to pilot this program very well for us, and for all the Aegis members who have attended today. Many more academic programs will be in stock for us in this coming year. For those who are non-Aegis member, we encourage you to join our program. I mean, join our association. There are so many benefits being part of this wonderful organization, and we tend to take minimal access surgery to the next level. By so saying, I want to wish all of us a very Merry Christmas, wonderful Christmas, and a Happy New Year in advance. We'll see you next year, God willing, with more wonderful programs and interesting topics that we'll learn from. Thank you very much. Have a nice rest. Good night.
Good night.
Yeah, good night.
Good night, and thank you very much.
Thank you very much.
Thank you.
Bye.
Bye. Thank you.
Dr. Gomez.
Happy holidays.
Thank
Thank
you
you so
very
much.
much.
Yeah.
Bye-bye.
So we can stop the recording. Where is it?